Hello everyone, my name is Dr. Vallabh Chawla and today we'll be doing a case report on apical extrusion of Gutta Percha or radiopaque sealer in the buccal vestibule area that is caused during the endodontic treatment. So, apical extrusion of Gutta Percha during the root canal treatment is the most means like the obturating material extends beyond the root apex region, beyond the apical foramen region into the periapical tissues. Okay, so basically, why does this apical extrusion of Gutta Percha happens? So, to study that, first we'll just check out the Cbct of this upper left side region. We'll just do the curve MPR marking. The curve MPR marking is to be done along the long axis of the tooth, and just study this in interval lines of 0.5 mm, and just hide the mid sagittal line and just bring this thing over here. We can appreciate this in the first premolar region. There's the buccal root and there's the palatal root which is seen. Okay, so palatal root, we can see this thing which is there is the radio opaque sealer. Okay, so this is the sealer or the radio opaque medicament. It could be anything. Okay, we'll just have a look in the, we'll just bring this visible cross sections to 5 just for a study of the buccal and palatal root together. So here we can see in the buccal root. Okay, so there is loss of lamina dura and periapical radiolucency may be evident, but now it is filled with the radio opaque sealer, as well as this lining which is seen over here is nothing but the overextension of the gutta percha as seen, and there is extrusion of radio opaque sealer in the periapical tissue, as you can see it over here. The radiolucent, sorry, the radio opaque sealer has extended and it has spread towards the phi region as well. That is 2 phi region as well, as you can see it over here. We'll just get these lines over here. You can just make it out. This is the radio opaque sealer, and the patient came with a chief complaint of swelling in the upper left side region. So you can make it out over here. And the size also, one can mark it and just have a look at the size as well. It's going you can just check it over here. 10 to 4 mm into 10 mm is the size. It's an ill-defined or irregular shaped radio opacity which is seen. So sorry, so you can just make it out over here. There is a periapical PDL widening noted in the buccal palatal root, and periapical radiolucency followed by radio opacity that is seen. There is loss of lamina dura. The root canal is does not have three-dimensional fill. And now we'll just have a look why this thing happens. Basically, just check this thing in axial cross sections as well. We'll just make these lines along long axis of the tooth and just check the axial cross section as well. We'll just hide the mid sagittal line as it versus the cross section, so you can just have a look, get this thing over here buccally. You can just see the amount of extrude tissue that has come out. So this is the extruded tissue that is present on the buccal aspect of the tooth, and also these are the coronal cross sections. You can also have a look at this in interval lines of 1 mm, just for the clarity, just to see from where to where it is there. So it's from the lower middle one third region till the apical one third region, and goes till the close to the sinus region. Same thing can be studied in the sagittal cross section. So we'll just study this thing in sagittal cross section over here. Okay, so from buccal to lingual, we'll just spread this line over here and just study the interval lines. So this is the buccalmost part, and as we go towards the lingual aspect, so this is the amount of the sealer radio opacity that is seen, and here the tooth is visible. You can see this is the buccal root, and this is the sealer mark, and this straight line which is there, that is the gutta percha or the overextended part. Similarly, this is the palatal root that is seen, and this is the sealer that is noted along with the periapical scar tissue. Sorry. So why does this apical extrusion happen? So the apical extrusion of gutta percha happens because of the incorrect working length. Like if one is not able to find the accurate working length that is seen, or they rely only on 2D radiographs where the apical anatomy may be distorted, or if the apical foramen is wide, or you can say it has an open apex. So these are the most common causes. Other causes could be because of the apical over instrumentation, where the enlargement is beyond the foramen, which allows the gutta percha to pass freely, or apical root end resorption because of the inflammatory changes. Suppose a tooth is grossly decayed and there is periapical pathology, and the periapical pathology has caused resorption of the root apex. So in such cases, also once the root canal is started, the sealer is extruded. Sealer is added in the root canal system, and it may extrude it out of the root canal system and go invade the periapical tissues. Also, if the root apex is funnel shaped, in such cases also there is apical extrusion seen. It is most commonly seen in young patients, or if the tooth is traumatized. So in such cases it is seen, and also it could be because of excess of pressure that is added, like vertical, while during the vertical or lateral condensation. If too much of force is added, it can lead to apical extrusion. And if there is there is apical perforation, or you can say excess of use of sealer, it can lead to this apical extrusion. So what problems can apical extrusion cause? It can lead to foreign body reaction, like in this case patient came with a huge swelling on the upper left side region, or say neurosensory complications like which is common in mandibular molars, not in maxillary, but still, like there will be pain and inflammation, post-operative pain and inflammation along with the swelling. So one has to take care of it, and hence in such cases usually CBCT is very much recommended. So because it will provide you a clear three-dimensional picture which a 2D radiograph may fail. So in CBCT you can see, like from each view you can make out, like this is the sagittal section, this is the occlusal view you can see over here, and the bird eye view you can see. You can just have a look at the root anatomy as well, like root and root canal system that is seen. So even the palatal root can be appreciated. So CBCT, it may help you to identify if there is any apical resorption or open apex or apical perforations, the curvature of the root canal system, and if the proximity of the structures. Like suppose if it was a mandibular molar, then usually the inferior alveolar nerve canal cortex is one of the major anatomical landmark, because it can lead to paresthesia in such cases. But there's a maxillary molar, so it can there are chances of it that it may just perforate the sinus or the floor, nasal floor, depending on the thickness of the floor. So treatment planning when it comes to CBC, how the CBCT helps. CBCT will help you in deciding the treatment plan, whether how the extruded material can be taken out, where is the location of it, and a surgical approach, whether episectomy can be done, and how a clinical decision is done by the endodontist or the oral surgeon, depending on the case to case. But it is very important in such cases to just get rid of the foreign body, a radiopaque extruded material. Otherwise, it could lead to foreign body reactions. And this is how CBCT is helpful, and it may be used as an adjunct in treatment planning. It is also recommended to take CBCT, single with high resolution CBCT, in such cases before the scan, wherever you're in doubt. Suppose in mandibular molars, if you feel that the mandibular molar root is in close proximity to the nerve canal cortex, then you can go for a CBCT before starting the root canal. Similarly, if you feel if the apex is open or resorbed, or if you feel like it is in close proximity to the maxillary sinus, it is recommended to go for a CBCT before starting the root canal procedure, just to get an idea about the apical end, whether the apex is open or closed, and how far away it is from the maxillary sinus. Like you can see here, the buccal root and the maxillary sinus floor are just overlapping. We'll just see this thing in thickness 12 mm. So, or you can say thickness 8 mm. So you can see this is the lining of the sinus. Okay, here this is the lining of the sinus. So in such cases, but we can see a good distance between the root and the maxillary sinus. So such cases, CBCT usually gives us a good idea about the proximity and how much gap is there between the tooth, root, and the sinus floor. So hence CBCT is usually recommended in such cases. Okay, for more cases you can check out my YouTube channel. There are many more cases of related to endodontic treatment, endodontic procedures, how to go about, and which may help you in the treatment plan. Thank you so much. Follow for more videos.